Good evening, all. Uh, Today we have a case presentation by Dr. Taral Patel. He is a third-year resident at MK Shah Medical College and Research Center, and his mentor is Dr. Hardik Shah. He is an assistant professor at the same institute. Welcome, Dr. Taral and Dr. Hardik. We have two subject experts, Dr. Chintan Vyas. He is a pediatric hemato-oncologist and bone marrow transplant physician at SRCC Children Hospital, Mumbai. And he has more than 12 years of experience in the field. And his areas of interest are leukemia, lymphoma, cellular therapies, hemoglobinopathies, and bone marrow transplant. He has done more than 200 stem cell transplants, and he has experience in pediatric cellular therapy. Welcome, Dr. Chintan.
Thank you. Thank you very much.
We have Dr. Geeta Khatwani. She is consultant pediatric hematologist, oncologist at Oncovin Cancer Center. Oncovin Cancer Center are at Naroda, Nava Vadaj, and Paladi. She is visiting consultant at Kothia, Starlit Hospital, Kothia, and Narayan Hospital, and many of pediatric units in Ahmedabad. And so her area of interest are pediatric hematology and oncology. So today's session is mostly on, there is a case presentation on hematology, and student will present, and whenever both the expert will feel like that you need some more clarification for any point of history or examination, or you want to ask anything to student, you can stop him in between and you can ask him. So, Dr. Taral, are you ready with your presentation? Should I share your presentation or? Is Dr. Taral there? I think he's there. Okay, he's there. Is there any issue in sharing?
Good evening, everyone.
Yes.
No. Can you hear me well?
Yes.
Hello.
Yes. Yes, you are audible.
Yes, sir. Yes, sir. You are audible.
प्रेजेंटेशन तो मुझे शेयर करना है, मुझे शेयर करना है प्रेजेंटेशन, लेकिन वो शेयर करने का बोल रहे हैं, वो पुराना वाला ही
नहीं, आपसे शेयर हो रहा है तो आप ही करो. आई थॉट कि थोड़ा इश्यू हो रहा है, दैट्स व्हाई आई आस्क्ड यू.
हाँ नहीं मैं शेयर कर देती हूँ.
यस.
हाँ नहीं मैं शेयर कर देती हूँ.
हाँ.
it visible, ma'am? Is it visible, ma'am?
Yes, it is visible now.
Yes, it
You
is
can
visible.
start, I guess.
Oh. May I start?
Yes.
Good evening, everyone. I'm presenting a case of a
You are
16-year-old
echoing.
So
Excuse me,
male
Taral.
child.
I think
You
you
are
have
echoing.
joined. You have joined
Yes.
from two instruments.
No, ma'am.
Your voice is echoing.
I'm joining from one instrument also.
Now it's
Only.
okay.
Hello. Okay.
Now it's fine.
Okay, ma'am. Okay, ma'am. I'm presenting a case of a 16-year-old male child residing at a Dhanduka, Gujarat, firstborn of a non-consanguineous marriage, belongs to lower middle socioeconomical class. Informant is a mother and she is reliable. Child is presented with chief complaint of chest pain for 2 days. History of present illness. Child was asymptomatic before 2 days. Then child developed a chest pain, which was located at xiphisternal and epigastric area, acute in onset, continuous, squeezing in nature, gradually increasing with severity, radiating to the left arm, not associated with any aggravating and the relieving factors. My child, this child is symptomatic since since 4 years of age. So I would like to elaborate the past history. Child was apparently normal up to 4 years of age. After that, he developed the fever, which was high grade, intermittent, associated with chills and rigors, relieved with medication, 2 to 3 spikes per day. There is no diurnal variation. Child is playful between two fever spikes. Mother also noticed that child had pallor, weakness, and decreased oral intake. So child was admitted at the hospital for 3 days. Some blood investigation was done and treated with IV medications and blood transfusion. Parents were told that their child had a low hemoglobin and he might have some blood disorder. They have been advised for the blood transfusion and asked for their and other siblings' blood testing. After testing, they have been told that both the parents and sibling had similar disease, but in the milder form. Child was on some oral medication once in a day since 4 years of age. Since last 8 years, child had repeated episode of the joint pain, which was located at the knee joints, which was acute in onset. Both knee joints are simultaneously involved, which is increased with exercise and decreased oral intake, and joint pain is improved with adequate hydration. No
So,
associated with any.
just I want to
Yes,
ask one
yes,
thing.
ma'am.
You told that the child has repeated episodes of joint pain. So, have you
Yes,
asked
ma'am.
about frequency of it? That how many episodes of such events in a year or in a 6 months period, or what was the actual frequency?
Ma'am, I have asked mother, not exactly sure about the numbers, but she told that approx in a 1 year there is a 1 to 2 episode, and in another year it is might be 2 to 3 episodes per year.
Okay, so every time
Yes.
for this joint pain, he need to get admitted.
No, ma'am. Only history of one-time hospitalization for the similar episode, and for which he is treated with the IV medication and blood transfusion. Another time, he is improved with the hydration and all that. No hospitalization required.
Okay. And one thing, is there any importance of consanguinity if you are suspecting any hemolytic anemias or anything?
Yes, ma'am. If it is a consanguinity between two parents, then it is increase the risk of sickle cell anemia and in the children.
But any other conditions?
Other condition. Sorry,
There are
ma'am. I
so
don't
many
know.
conditions in that consanguinity matters.
Yes.
Also in hemolytic anemias, which other?
Ma'am, is a thalassemia or a G6PD deficiency.
Okay, and one other thing I want to ask, this patient is from Dhanduka. Is there
Yes, ma'am.
any relation between from what area patients come to you and address of patient, and also any relation with caste in blood disorders? Is there any relation with caste?
Yeah, yes, ma'am. First of all, there is a sickle cell anemia is mostly seen in the hilly areas. Then another is a thalassemia is seen in the certain state is most frequent like Gujarat, Madhya Pradesh, Maharashtra, Odisha, Chhattisgarh. There is a thalassemia belt, and another is according to caste. There is a thalassemia is more common in the Punjabis, Sindhis, and then Muslims and Khatris and that population, Lohanas, in their most much.
And in Gujarat, in which part of Gujarat these diseases are common? Is there any geographical variation?
In Gujarat, ma'am, uh, it is
We
a
particularly ask that history. If we suspect some hemolytic anemia, then we ask that what is the area of origin.
uh, I'm not sure, ma'am, about that.
In South Gujarat, it is more commonly seen.
Yes, ma'am.
In Gujarat.
Okay.
Do you know any theory behind why these certain diseases are common in certain regions? Like in African countries, also this sickle is more commonly seen.
Ma'am, initially in African region, there used to be a lot of deaths due to malaria.
Yes.
So, as a
Yes.
protective mechanism, by Darwin's theory, the disease got evolved in such a way that the habitants are protected from disease.
Yes. So there is a mutation for benefit of generations. So there are this mutation will lead to this disease. So there are particular regions are involved. Okay.
Yes, ma'am.
Any expert want to ask anything till now?
So basically, you have said that there were multiple painful episodes. So have you asked that painful episodes responded to which drugs?
Ma'am, child is on some oral medication since 4 years of age. So mother specifically told that after that medications and with hydration, child is improved with that.
And that medication the child is taking is in which form? It's a syrup or a tablet or a
No,
cap.
it is a tablet form. It is a tablet form, and child is consuming once in a day.
Okay.
So she told about history of any painkillers she is giving.
No, ma'am. She is told that she had given painkillers only 1 or 2 times. After that, she not given any painkillers, and it improved only with the hydration and
So is there any seasonal variation in symptoms, or during certain illnesses patient is getting this pain? Do you have noticed anything like that?
ma'am, it is mainly increased during the exercise and all that. It increases.
In summer season or anything? There is no
No,
any
ma'am. Mother
correlation with
told
that.
that when heat. Ma'am, mother told that when a child is taking less fluid, less consuming the fluids, then it aggravating by that.
Okay. Is there only joint pain, or there is swelling also?
No, ma'am, there is no swelling. Only joint pain was there.
And only knee joints are involved, or other joints were also involved?
Yes, ma'am. Only knee joints are involved.
Okay. You can carry on.
Child is operated for child was operated for the inguinal hernia 4 years back. Blood transfusion was given at that time. Since last 6 months, child had 2 to 3 episodes of chest pain, which was mild in nature and relieved without any treatment. There is no history of cough, cold, and fever. There is no history of
So
breathlessness
just
and
wait
palpitation.
for a moment.
Yes.
You need to
Okay, ma'am.
explain your negative history. So why have you
Okay,
asked
ma'am.
for cough and cold?
Ma'am, due to chest pain, I want to rule out any LRTI and respiratory tract infection. So I have asked for the cough, cold, fever, and breathlessness. Then there is no history of pain while respiration. I want to rule out the pleurisy pain. Uh, no history of any bluish discoloration of the nails and the lips due to acute chest pain. It will lead to the cyanosis or any cardiac condition due to which I want to rule out.
Just a minute.
Then
Just a minute.
no history of any.
Just a minute, Taran.
Okay, ma'am.
What was the site of
Okay.
pain?
Okay.
What was the site of chest pain?
Ma'am, it is mostly at the episternum and epigastric area.
It is more like abdominal, no?
Yes, ma'am.
Is there
It
any
is
specific side that it is on
episternum.
left side or right side, or there is any?
No, ma'am. No, ma'am. No, not specifically.
Okay. So you were at bluish discoloration
Then
of
there is a
nails and lips.
yes. Then ma'am, no any history of edema and decreased urine output. So I want to rule out the any signs of CCF. There is no history of passing the high colored or red color urine. I want to rule out any hemoglobin urea. No history of blood in vomitus and black tarry stool. Due to I want to rule out bleeding
What do
from
you
any
mean by
other
cola
sites.
colored urine?
It is a dark cola color, reddish urine, which is seen in the hemoglobin urea and glomerulonephritis.
So when do hematuria occur and when do cola colored urine occur? I think the experts are okay with my questions now. Dr. Chintan and Dr. Geeta, if you want to ask in between something, please.
Yes, yes, ma'am.
Ma'am, hematuria is the presence of red blood cells in the urine, and cola colored urine it is due to degraded hemoglobin in the urine, and it is due to dark color because of that.
Okay.
Then there is no history of any blood in vomitus and black tarry stool due to any bleeding. I want to rule out any bleeding from other sites or not, blood loss. No history of any joint swelling and generalized rashes. So I want to rule out any inflammatory causes of joint pain. There is no history of syncope, seizures, weakness of limb, visual disturbances, and blackouts. I want to rule out for the any sickle cell crisis because there is a significant past history. So I want to rule out of that. There is no history of any outside food consumption. I want to rule out any GERD and gastritis. No, there is no history of trauma, so I want to rule out it is any due to myalgia or musculoskeletal pain or.
Okay. So do you know what is the most common reason for chest pain in pediatric age group?
Most common. No,
Yeah,
no,
you must be seeing OPDs, na? So patient must be coming to you, specifically adolescents.
Yes.
Yes.
Yes,
So
ma'am. It is a chest center of the chest most commonly.
no, I am asking you what will come in your mind if some patient at 12, 13 years of this age, also 16 years, come to you with chest pain? What will be your
it is anxiety or panic attack. It is in
so
this
that
age
will be
group.
associated with
Sorry?
patient may have some other symptoms also na, if anxiety is there.
Yes. Yes,
So,
ma'am.
and palpitation and tachycardia will be there.
Yes,
So
ma'am.
that will cause that much significant chest pain?
Musculoskeletal.
Yes, musculoskeletal.
Musculoskeletal.
That is more common.
Yes.
You told that this patient is having pain, and what was the type of pain?
Mother told it is a squeezing type of pain, and it is acute in onset, and it is gradually increasing in severity.
So you told that there is no any aggravating or relieving factors. So which may be
Yes,
the
ma'am.
aggravating factors? Which factors have you asked?
Ma'am, I have asked for if pain is increasing while the coughing or any movement, then it is a pleurisy pain, and then it is a other factor is when pain is increasing on sitting and decreasing on leaning forward, then it is a pericarditis, maybe pain associated with pericarditis. So it is a aggravating and relieving factor, which I know.
This pain is in epigastric region. So what may be the reason?
Yes, ma'am.
What do you think?
Ma'am, it is other cause. Epigastric pain is a GERD. It is a so it may be one of the reason for that.
Can gastritis cause that kind of pain?
Yes, ma'am. Gastritis can cause.
Patient do not have any history of vomiting, na?
No, ma'am.
Okay. Tell your further history.
It's a
So what is your,
family
just
history.
tell me one thing. What is your differential diagnosis up till now? You have completed your present history. You also told us about any past, all the past events and the negative history. So what you are
Yes.
suspecting? This patient is having what is the reason behind chest pain?
Ma'am, first of all, as per the history, first of all, I will suspect the any hemoglobinopathies due to significant past history. Second one is I want to make as a differential diagnosis is a juvenile idiopathic arthritis, but it does not fit in that criteria. Other is I can make it as a rheumatic heart disease, but again, which is not fit in the criteria. So up to now, most probable diagnosis is any hemolytic anemia. Most probably, ma'am, it would be sickle cell due to picture is suggesting of feature of crisis. So.
So which type of crisis?
Ma'am, it may be due to acute chest syndrome and there is a knee joint. Maybe usually in the hand foot syndrome or dactylitis, there is a pain in finger and limbs, but maybe might be child is having the knee joint which is presented as that vaso-occlusive crisis.
Okay. Dr. Chintan, do you want to ask her something related to this complaint? Is this? I don't feel like these symptoms are fitting into acute chest syndrome.
Yeah, so
What is your
actually I
opinion?
want to, yeah, can you hear me?
Yes, sir.
Yeah,
Yes,
so
sir. Yes, sir.
absolutely that not very classical fitting into this. I was just waiting
Yes, sir.
for a few more slides and wanted to hear the story. So when you would like to
Yes.
describe about the symptoms of acute chest syndrome or any painful crisis, na, you need to mention the symptoms
Yes, sir.
like an onset of symptoms, precipitating factors, severity of the symptoms, whether the patient needs hospitalization for that, what kind of treatment has given, whether IV treatment has given, oral treatment has given, all these things has to be told, and then
Yes, sir.
only you can justify whether it can be a
Yes, sir. I have mentioned
yeah.
previously that child had repeated episodes of joint pain, and for which he got hospitalized only one time, and for which he was treated with the IV medications and blood transfusion. And previously, child had 2 to 3 episodes of the chest pain, but which was mild in nature and does not require any treatment in past.
So whenever you describe any painful crisis, right? Particularly when you are dealing with painful
Yes.
crisis because of the vaso-occlusion,
Yes,
right? See, chest pain is a very non-specific symptom, and that
Yes,
too,
sir.
your age of the child is so when he presented with chest pain, what was the age of the patient? At what?
First of first stage is sir, it is a
4 years
13
is a
years.
presenting age, right? Huh? 4 years means
4
like
years
just a 13
presenting
years.
it. Chest pain is sir, first episode is in 6 months back, and second episode in now.
So he is like 10-year, 11-year-old now.
So 16-year-old now. So first episode at the
16-year-old.
15 year of age. Yes.
Yeah. So whenever you, first episode at 15 years of age, right? So whenever
Yes.
you describe these kind of symptoms, just chest pain may not
Mm.
be only important. Like what kind of
Yes, sir.
other factors associated with pain, even if you
Yes, sir.
describe, see, there's a very good mnemonic to describe the intensity and severity of pain, like
Yes.
severity, consistency, onset, aggravating relieving factor, time,
Yes.
and all these things, what position. So these are the things which you need to describe for the pain, and then you need to correlate the chest pain with your precipitating factors, and that's how you can describe, because chest pain can simply gastritis, chest pain can be
Yes, sir.
muscular, chest pain
Yes,
can
sir.
be anxiety induced, anything can be there, right? So if you are
Yes, sir.
describing chest pain causing pneumonia, acute chest syndrome, which is a vaso-occlusion, you need to be more detailed in asking the associated history.
Yes, sir.
And I think most important in this case is severity. So and he's an adolescent boy, right? So he's able to
Yes.
tell the complaints at his own. So what was the severity? Was he able to deliver the symptomatology himself? Was he restless or was he comfortable? What were the pulse
No,
rates?
ma'am. Yes, sir. Hello.
Hello,
Hello. Hi, ma'am.
hello. So was he able to deliver the symptomatology himself?
Yes, ma'am. Yes, ma'am.
And he was in a comfortable position to deliver the
Yes, ma'am. It is a comfortable. He was in the comfortable
sort of.
position, and he delivered his.
Okay, okay. And any symptoms did he take to relieve that pain? Any treatment did he take to relieve that pain at
Uh,
home
uh,
or nearby OPD centers?
no. No, ma'am. They not received any treatment. Relieved by itself.
Oh,
Mother told that.
okay, okay.
May I proceed, ma'am?
Yes, please.
As a family history, mother is a known case of a thalassemia trait. Father is a known case of sickle cell trait. His twin sister is a known case of a thalassemia trait. There is no history of blood transfusion in the family, and no history of any other illness in the family. Antenatal history. It was a registered pregnancy. Yes,
Final
ma'am.
one. Did you ask for family history, extended family history?
Yes, ma'am. I have asked, but no any other illness or any blood disorder in the other family members.
Yeah. So basically, if you are suspecting a hemoglobinopathy or a hemolytic disease, what other history will you ask other than only transfusion?
Ma'am, history of any gallstones or history of any cholecystectomy or splenectomy. We have asked for that.
And jaundice.
Sorry, ma'am?
History of jaundice.
Yes, ma'am. History of jaundice.
Okay, okay.
Okay. Antenatal history. It was a registered pregnancy and immunized. Mother had taken 5 to 6 antenatal visits and iron folic acid supplements. No any significant illness during the pregnancy. Birth history. He was a preterm, born by LSCS. Hospital delivered twins, male child, 2 kg, tried immediately after birth. History of NICU admission for 15 days for low birth weight care. There's a diet history. Child is taken the 1600 kilocalorie and 14 gram protein, deficit of 300 kilocalorie and 1 gram of protein. So no significant deficit of calories and protein. Immunization history. Child is completely immunized till the age of 10 years as per national immunization schedule. No any optional vaccines were taken. Developmental history.
So just a
All
minute.
milestones.
Just a minute,
Yes,
Taran.
ma'am. Yes, ma'am. Yes,
Is there any specific vaccine importance of vaccination in hemolytic anemias?
Yes, ma'am. We have offered some optional additional vaccines to the patient of hemolytic anemia, like pneumococcal, which is protected against the capsulated organism, which was a pneumococcal, H influenza type B, meningococcal. So all vaccines are required for that,
In national
especially in the
immunization
splenectomy
schedule,
patient.
in national
Yes,
immunization
ma'am.
schedule, at what is the schedule for pneumococcal vaccine?
Pneumococcal vaccine is the first dose is 6 weeks, second dose is 14 week, and booster dose is 9 months.
So what type of vaccine that is what strains are included in national immunization schedule? Which how many valent vaccine pneumococcal?
PPV
In
23.
NI, what valent pneumococcal is given? Which type of pneumococcal vaccine?
PCV
23.
conjugate 23.
No. In national immunization schedule, what vaccine is given for pneumococcal?
Uh, um, it's a conjugated vaccine.
Anybody wants to tell?
PCV all
It is 10 valent.
10.
So once child has received that schedule 10 valent, okay. So
Yes.
if child is having hemolytic anemia, then do you want to give any other pneumococcal vaccine?
Pneumococcal vaccine.
Child has
It is a
received 10 valent vaccine.
Yes, ma'am. PCV 23. I want to give Prevenar. Yes.
So you need to give 23 valent.
Yes, ma'am.
Okay. Second thing, you told me about pneumococcal. What other vaccination should be completed in this child?
It is a influenza vaccine. Then meningococcal vaccines. Other is a typhoid and hepatitis A.
Okay.
Then developmental history. All milestones achieved as per age. Patient is in the 10th standard with good scholastic performance. Socioeconomical history. There is a 4 members in the family. Father education is a higher secondary and shop owner. Mother's education up to 10th standard and she is a housewife. Family income is 20,000 per month. Type of housing is pakka. There is no overcrowding. So it is fall under the modified Kupuswamy classification type 3, lower middle class. So my history summary. 16-year-old male child, firstborn of the non-consanguineous marriage, presented with chief complaint of chest pain for 2 days with recurrent history of joint pains and chest pains, with history of 3 times blood transfusion and family history of blood disorder. Most likely system involved is a hematopoietic system.
Is there any family history of blood disorder? You didn't mention previously.
No, I mentioned that mother is a known case of thalassemia trait and father is a sickle cell trait and twin sister is also known case of thalassemia trait.
So they have a status of trait, no?
Yes,
They
ma'am.
do not have a disease.
No, ma'am.
Only
No
trait
any
is-
disease.
So can I ask one thing?
Yes, sir.
Yes, sir, definitely.
Yeah. So when you summarize history, na, go back to your summary.
Yes.
Yeah. So with chest recurrent history of chest pain and joint pain since sorry to a recurrent history of chest pain and joint pain. Now, see, I don't expect that you write 10 pages, 10 line summary, but even a 5-line summary can give you the proper. This summary is not absolutely telling you that this is a chronic disease. What do you mean by recurrent? How many days? How many episodes he has had happened? He had that in last 1 year or 2 year or 5 years or like that. So number of episodes can be very well described in 2 words or 3 words.
Yes,
Secondly,
sir.
how many episodes of hospitalization or whether the severity of symptoms were requiring hospitalization and IV
Yes, sir.
drugs, including
Yes, sir.
analgesics and antibiotics, right?
Yes, sir.
And
Yes,
then
sir.
history of 3 times blood transfusion. That does
Yes.
not mean anything. History of 3 times blood transfusion in what interval? Whether it was given one at 4 year, one at 10 years, and one at 11 year, like that. So
Yes.
with a family history of blood disorder, family history of blood disorder is not the right thing.
Yes,
With
sir.
you need to mention that family history of sickle cell and thalassemia, right?
Yes, sir.
Because now if you
Yes,
are
sir.
summarizing the history and if you have already mentioned in your family history that there is a sickle
Yes,
trait
sir.
and thal trait,
Yes, sir.
then there is no point of putting like blood disorder, right?
Yes.
So
Okay, sir.
if you have written 4 lines in your discharge in your history of summary, it does not
Yes, sir.
make any sense, right?
Yes.
So you need to be
Yes,
very
sir.
cautious then when you are describing the chronic illness in the
Yes, sir.
summary. So I would describe this in like a 16-year-old male, product of non-consanguineous marriage, with age with symptoms of onset at this age, with this
Yes.
much episodes in since this time, and
Yes.
like number of episodes of chest pain and joint pain per year, requiring hospitalization for so many days or not requiring hospitalization, requiring IV medications to relieve the symptoms or to requiring IV antibiotics to relieve the chest problems.
Yes.
In the absence of any other constitutional symptoms like chronic, like a prolonged fever or weight loss, which can suggest any other thing except the hematopoietic system, I would say a chronic tuberculosis or a chronic rheumatological disorder or anything else, like, right? So if you are only thinking of sickle cell disease, right,
Yes.
then also
Yes.
this summary is not enough. And if
Yes.
you want to put a differential diagnosis, then also
Yes.
this summary is not enough. So if you think that you will examine hematopoietic system first, but in your summary you should mention that except hematopoietic system, can this be a case of liver disease? Like chronic liver disease
Yes.
patient can also have these vague symptoms, correct?
Yes, sir. Yes, sir.
Right? So
Correct, sir.
that is an thing. That is an important thing. So you have neither justified a sickle cell disease or hemoglobinopathy in this summary, nor you have ruled out the other chronic systems which can lead to recurrent pains, recurrent blood transfusion and all. I am telling you,
Yes,
if
sir.
you see with the bullseye, you will only be able to describe what you are describing. But we as an examiner don't do that, right? There can be
Yes.
an n number of differential diagnoses, at least 3 differential diagnoses in one case, even if it is a diagnosed case of sickle cell disease or a
Yes, sir.
thalassemia.
Yes, sir. Right. Correct, sir.
Can you re-summarize?
Yes, sir. There's a 16-year-old male child, first born of a non-consanguineous marriage, presented with a chief complaint of chest pain since last 2 days. Which child had a history of recurrent joint pain since last 8 years with frequency of 1 to 2 episodes per year, for which he required hospitalization one time. Then he had a history of recurrent chest pain in last 6 months, 2 to 3 times, for which he doesn't require any treatment. Then with a child had a history of blood transfusion, and there's a family history of mother is a thalassemia trait, father is a sickle cell trait, and her twin sister is a thalassemia trait. So most
Right.
likely,
And whenever you present any case, whenever you summarize any case, you have
yes,
to summarize what was your nutritional history, what was your development history, what was your growth history, right?
yes,
So
sir.
in
Yes,
a
sir.
developmentally otherwise normal child,
Normal.
with whatever growth, you have you have found out in your history, with
Yes, sir.
additional nutritional with adequate nutritional intake,
Yes,
um,
sir.
and well immunized. So I mean,
Yes,
these all have you have covered in history, right? So you have to just summarize,
yes,
because
sir.
see, if you have
Yes,
a recurrent infections or recurrent hospitalization, you may not be well immunized, right? Or if you have
yes,
chronic problems, your growth will falter, right? Although you will
yes,
examine, you will take the examination thing about growth, but at least you can
yes,
summarize in your history that how the child overall was growing, right?
yes,
And
sir. Yes, sir.
development history, right? Because
Yes, sir. Yes,
with recurrent these things, and if the patient is not doing well in terms of the holistic performance, in terms of
yes,
the cognitive ability, this patient may be developing silent infarct in the brain, right?
yes, sir.
So
Yes,
I'm telling you, hematological case is not only hematological, right?
yes,
You have to look at each and every system, correct? So you
yes, sir.
have to mention
Yes,
that
sir.
this child is neurologically, developmentally, cognition wise normal. So in that, everyone knows that you have examined child not with just one diagnosis, but you have examined the
Yes, sir.
child of a chronic illness thoroughly as a general pediatrician,
Yes,
right?
yes, sir. Yes, sir.
So
Yes, sir.
always
Correct.
complete your summary with development, nutritional growth, and immunization history. Okay.
Yes, sir. Yes, sir. Correct.
Yeah, I can carry on now.
Yeah.
If Dr. Geeta wants to add on anything, because these are very common cases, right, Dr. Geeta?
Yes, yes, absolutely. Because whenever we see a child, we don't look only at a system. We see it as a
Yes,
child only whole.
yes, sir.
And even even if you consider sickle cell disease only, it's a disease which involves multiple systems altogether.
Yes, sir.
You can go ahead.
Uh, there's a anthropometric. There's a weight is a 45 kg. Expected is 57 kg. It is between 3rd to 10%. Height is 164 centimeter. Expected is 168 centimeters. So it between 25 to 50%. BMI is 16.7 kg per meter square, which is between 10 to 25 percentile. So child is at growth wise is normal. Vitals. Temperature was 98 degree Fahrenheit in right axilla. Pulse is 98 per minute, which was regular, good volume, no radiofemoral delay. Respiratory rate was 22 per minute, thoracic. Blood pressure is 118 by 62 mmHg, between 50 to 90%, measured in supine position on right arm using appropriate BP cuff. SpO2 is 98% on room air. General physical examination. Head shape is normal. Pallor is present in lower palpebral conjunctiva and palm. Icterus is present in the sclera. Nose, ears, and oral cavity is normal. BCG scar present in the left on the left upper arm. Chest is normal. Abdomen scar of the herniatomy is present on right side. No any distension. Back and spine is normal. genitals is normal. No any cyanosis, clumping, edema, and lymphadenopathy. As per my history,
Just a
I would.
minute. Taral,
Yes.
have you told about
Yes, ma'am.
SMR staging of this child?
That was saying.
No, ma'am.
So do you think, is it important or not?
Yes, ma'am. It is important.
So Dr. Geeta, please, if you want to ask anything to her regarding this.
So, but basically, I was saying the same. It's a child of belonging to the age of puberty. So,
Yes.
SMR is important because once the child
Yes.
crosses years of age, only growth and development is not only important, but puberty, whether he or she has achieved puberty or not, that is also a sign of new development which is added in child's life.
Yes. Yes, ma'am.
So, you should
What
consider.
very other? Yeah, sorry, Dr. Geeta. Yeah.
No, you can go ahead. So, but I was saying that you should consider him or her as a teenager and examine accordingly.
Yes. Yes, ma'am.
Yeah. So in general examination, which part of body you missed in your examination, which is extremely important? Extremely important.
Which is extremities.
Absolutely. What do you mean? What would you like to mention on the extremities?
If there any swelling or present over the fingers. Or
Okay, that is one thing. Second,
Presence of ulcerations,
yes, absolutely.
yes,
Where?
palpation of leg ulcers.
leg ulcers,
Leg
leg
ulcers.
ulcers.
Leg ulcers.
Right. And that is very important. Absolutely important.
Yes.
So by what age usually patients start developing leg ulcers in hemoglobinopathies? I would say sickle or Thar intermedia or something like that.
Around 6 to 8 years.
6 to 8 years.
Yeah, I don't remember.
So usually after years or 8 to 10 years, usually in the adolescent age group, right? It doesn't happen in the beginning because it's a chronic vasculopathic changes, right?
Yes.
And that's why it doesn't happen in the first few years of your presentation. It happens usually later. And particularly it is more common who has a presentation early onset. Like if you have a late presentation where you have a severity of symptoms very mild, probably you may not develop leg ulcers. But let us say if this child would have presented at 4 years of age and now he's 16 years of age, by this time, sometimes quite a few patients of these presents with leg ulcers after 8 years or 10 years, something like that.
Yes. Yes.
So don't forget, these are very pinpoint findings of your case. Huh?
Yes, sir.
And did you also look for any hyperpigmentation?
Yes, ma'am. Hyperpigmentation of knuckles.
Was it there or was it not?
What not present, ma'am.
Okay. And why is it important to see knuckle hyperpigmentation?
Because it is associated with any megaloblastic anemia or what.
And what uh, conditions precipitate megaloblastic anemia?
Like folic acid deficiency and
So folic acid deficiency and B12 deficiency causes megaloblastic anemia. Which conditions
yes.
precipitate megaloblastic anemia?
Usually, when the demand is high, such as in hemolytic anemia, where there's increased cell turnover rate. So,
Yeah, so basically, whenever there is high turnover or high demand, it precipitates the B12 and folic acid deficiencies, like in cases of hemolytic anemias or pregnancies, adolescents, especially vegetarians. Did you ask about this, whether the child is non-vegetarian?
Yes, ma'am. He's a pure vegetarian.
So
What
does
will
it have any increased chances of B12 deficiency?
Sorry, ma'am.
Being a vegetarian, does it increase the chances of B12 deficiency?
Yes, ma'am. Yes, ma'am.
Okay. So that's why mentioning knuckle hyperpigmentation is also important in this case, because already he's a vegetarian and
Yes, ma'am.
he's suffering from a condition where there is increased turnover and increased demand of B12 because of ongoing hemolysis, right?
Yes. Yes, ma'am.
Okay, you can continue, I think.
Okay. So, systemic examination. So, according to history, I am suspecting the hemolytic anemia. So, first of all, I would like to examine the abdominal system first. On inspection, abdominal shape is normal, no any flank fullness. All quadrants are moved equally with the respiration. Umbilicus
And
is normal in.
mentioned vitals, na, right now, saturation, heart rate, etc.
Yes, ma'am. I have mentioned already.
Do you feel the child was in crisis?
No, ma'am.
Why?
Because ma'am, child was having only chest pain. There is no any other symptoms associated like respiratory distress or fall in the saturations, and he was not tachypneic and no any signs of respiratory distress. Um, Only chest pain was there.
And there was no tachycardia also, right?
Yes, yes, ma'am.
So whenever there is pain which is clinically very significant, even when the child is silent, there will be a significant tachycardia.
Yes, ma'am.
These vitals were recorded during presentation or after
Yes.
symptomatological treatment. These vitals
No,
are
ma'am. During
at present.
presentation. Yes.
Okay.
And
Umbilicus is.
Dr.
Yes,
Tara,
ma'am.
your patient presented with chest pain. So I think you also need to examine respiratory and CVS system. As a sickle
Yes,
cell itself is a systemic disease. If you are
yes,
suspecting
yes,
that
ma'am.
also, then you need to examine these both systems also.
Yes, ma'am.
So
Uh,
that findings are there na in these slides.
yes, ma'am. In the next slides. There is a scar mark of the herniatomy is present on the right side. No any visible dilated vein, peristalsis or pulsation. On palpation, on superficial palpation, temperature is a normal. There is no any tenderness, guarding or rigidity. No organomegaly. On normal vowel sounds are present. Other system examination, respiratory system examination, chest shape is normal, bilaterally symmetrical, no any deformity, and moves equally with the respiration. On trachea is centrally placed and no any deviation. There is no tachypnea and no signs of respiratory distress, no any scar marks or chest deformity, no any tenderness, normal vesicular breath sounds are present, no additional sounds heard. On cardiovascular systems, chest shape is normal, no any precordial bulge. Pical impulse is palpated at the left fifth intercostal space, just medial to mid clavicular line. No any visible pulsation. For S1 and S2 is present, no any murmur. On CNS, central nervous system, no any significant finding. Summary. 16 years old male child, first born of a non-contiguous marriage, presented with chief complaint of chest pain since last 2 days, with a history of recurrent joint pains since 8 years of age, approximate 2 to 3 episodes per year, for which he required one-time hospitalization. History of chest pain since
So
2 to 3
stop. So
episodes
I would like to,
in last.
Taral,
Yes,
when you are describing the
yes,
repeated history now, so just don't repeat everything because the examiner
yes, sir.
get bored if you are repeating the same thing again. So just in the background of the
Okay.
summary history which I have given, I would like to summarize the examination
Yes.
finding, and in that way you will be able to describe
Okay.
your examination finding more. Because if you are repeating the same thing
Okay, sir.
again, then you are losing
Yes, sir.
the second part of the history taking, sorry, this case presentation, which is examination. So try to
Yes,
focus
sir.
more on examination. And just to say,
Yes.
in the
Yes,
background of
sir.
summarized history which I have given, I would like to
Okay.
summarize the examination finding and then would like to give a differential. So don't repeat things. It is a bad habit.
Okay. Okay, sir. According to my previous background history, with positive examination findings are pallor and icterus, I would think child may have a chronic hemolytic anemia, most probably sickle cell anemia.
Again, I have told you, you have to describe the important negative findings. Because you want to rule out other system disorders, right? So, I mean, you have to
Yes.
make sure that the examiners listen that what you have ruled out.
Yes, sir.
And I'm not telling to rule out, telling to mention 10 negative history, but only
Yes, sir.
3 or 4 negative history, negative examination finding, like no organomegaly, no
Yes, sir.
lymphadenopathy, no other features suggestive of chronic anemia like leg ulcer or any other things, right?
Yes. Yes, sir.
And you mentioned one thing which I forgot to ask. You mentioned herniatomy scar. Where was the scar?
It is a lower part of the abdomen, sir.
What do you mean by lower part of abdomen?
In the inguinal region, sir.
Okay. In the inguinal region, right side, left side,
Right side, sir.
right side. So, are you sure? Was it a inguinal? Was it a herniation scar? Post herniatomy scar?
Yes, sir.
How were you very sure? Did you ask a direct question? या patient ने खुद directly told you कि it was a hernia
मतलब
operation?
patient parents not that knows that there's a hernia operation.
Why I am asking this question?
Because splenectomy was previously done or not, that we want to rule out.
In sickle cell, you sometimes by this age you get autosplenectomy, so no question of splenectomy.
Yes.
Yes.
Why I'm asking, and why I'm asking which side, right side, left side, which part of abdomen? Why I'm asking these specific questions?
Left side it is a maybe due to splenectomy scars.
This patient had your right side problem, na? Right side
Yes,
scar,
sir.
na? What is
Yes,
there
sir.
in right side?
It is a liver.
Cholecystectomy was also done or not?
Cholecystectomy.
Obviously,
Yes.
cholecystectomy is more important in case of
Yes.
hemolytic anemia like sickle cell disease,
Yes.
right?
So
Splenectomy
Yes.
doesn't.
yes. So by 16 years of age, mostly there will be a functional asplenia. But sometimes in other cases, like we are thinking of other hemolytic anemia, we wanted to just rule out
Absolutely.
like splenomegaly.
Yeah, but there was no
So
splenomegaly, so we don't focus on
yeah,
that. But yeah, this is
yes,
very
yes.
important. See, if you are mentioning a scar, then it is fine that the patient has given the history of hernia. But if I am
Yes.
an examiner, I would 100% think that this could be a cholecystectomy scar,
Yes,
right?
sir.
Yes,
Because it's a right
Yes, sir.
side. It's
localization.
yeah.
Yes, sir.
Hmm?
Yes, sir.
So summarize the examination positive as well as important negative findings, which rules out other disorders like chronic liver
Yes, sir.
disease.
Yes. So, sir, there is, according to my background summary, there's a positive examination findings are pallor and icterus with there is no any signs of ascites and lymphadenopathy and no any other no any signs of
No organomegaly.
No
organomegaly.
organomegaly or knuckle pigmentation was not there.
Knuckle pigmentation.
Right, with cardiological, neurological system being normal,
Neurology stable, normal.
right? Right.
In
And
Yes,
cardiological,
sir.
in CVS examination also we can expect to see for the hemic murmur or pulmonary loud P2 in case of
Yes.
pulmonary hypertension. So that we were
Yes.
expecting, so that need to be like mentioned in the negative like finding.
Yes.
right? And when you are describing any case of sickle cell disease, you cannot forget central nervous system. Okay,
Yes, sir.
you
Yes.
may be
Yes.
finding a normal child, walking child, talking child, right? But
Yes.
you have to find out if there is any subtle signs of any weakness, of any involuntary movements or anything like which can suggest, which can push you to evaluate.
Yes.
In general, we usually prophylactically evaluate, but
Yes, sir.
if you don't prophylactically evaluate, you are sitting in a busy OPD, right?
Yes.
You cannot forget central nervous system in sickle cell disease, okay?
Yes. Yes, sir.
So what are your differential diagnosis?
So,
And
sir,
and
my
the other
differential.
thing, see, other thing which I would like to tell you very clearly, that when you
Yes.
are describing a chronic hemolytic anemia,
Yes.
right, it cannot be simple anemia. It is always a disease, right, or a
Yes, sir.
disorder, right?
Yes.
So sickle cell anemia is like a sickle cell trait. They don't have the these many symptoms. So it's a disease. It's not anemia, plain and simple anemia. It's a
Yes.
sickle cell disease or a
Disease.
thalassemia. Thalassemia, how you describe thalassemia, major, intermediate, minor, whatever it is.
Intermediate.
Right?
Yes.
Yeah. So sickle cell anemia is not the right terminology. This patient is already throwing symptoms. So it's no more anemia,
Yes, sir.
right? It's a disease.
Yes, sir.
And
Oh,
you cannot
okay.
write just
Yes.
one diagnosis in your summary. You have to make sure that you give the differential diagnosis. Otherwise, examiner will know that this is a sickle cell anemia case which is already known
Yes.
to you,
Yes.
right? So
Yes.
that's not the right approach.
Yes.
Sir, ex- sir, I
How
had one doubt.
is a chronic anemia and not acute? Say that this anemia is chronic and not acute.
Sorry, ma'am. Couldn't hear.
How can you say that the patient had anemia but it was not acute? It's a chronic
Yeah.
anemia.
Okay, ma'am. There is a previous long history which age of onset at the 4 years with recurrent history of symptoms like joint pain and chest pain which required blood transfusions. I have thought of chronic
So here
hemolytic
actually the onset of the we thought history since last 4 year of age, and
Four-
first time transfusion was done at the 4 year of age, and
4
it was
years of age.
diagnosed. And second time before this, yes, 4 year of age, and second transfusion was done before the surgery. So till now there are 3 transfusion,
times.
and this is the third time we admitted the child, and that time we transfused. So we thought like that onset of the disease is like since 4 year of age, and three times we have transfused.
Why
But
it
the
is not
again,
like acute on chronic?
hello.
Why it is something not like acute on chronic?
If it is acute, we are thinking acute event. So the previously blood transfusion, that is the previously 3 times blood transfusion, that is against the point. And the for the chronic hemolytic anemia, one thing is against the diagnosis is like if there was no hemolytic phases. So that was the only one thing, and there was no any hemoglobinuria. If it is acute onset, we may get the jaundice. Icterus might be there.
So basically, there are many hemoglobinopathies which present with anemia. But in this case, there is the patient was hemodynamically stable.
Stable,
Yes.
yes.
Yes, so that is the point that there is something which was going on chronically, but कुछ acute precipitation अभी नहीं हुआ है क्योंकि आपने जो भी vitals बताए that all were okay, because even hemolytic being chronic, since the presentation is 4 years of age, can present with some certain acute events, right?
Yes,
Yes,
it
yes.
may present with the acute events. That time we can expect all the like vital changes, tachycardia and all,
The patient was
desaturation
unstable.
due to the hyperdynamic circulation. So chronic hemolytic anemia can be present with the acute event also. But
Yes.
certainly here there was significant past history, so we are considering.
And we are not considering any acute event here right now.
So can we say it is a sickle cell because
Yes,
the
yes.
father was sickle cell trait and mother thalassemia trait? In sickle cell, both the parents should have been a sickle cell trait, right?
So basically, as Dr. Chintan rightly said, that it is not sickle cell anemia, it's a sickle cell disorder or sickle cell disease. And sickle cell disease,
Disease.
multiple spectrums. Homozygous sickle cell can also come under this, and even sickle cell can also come under it. But you cannot say it before if you do not have the HB electrophoresis of patients or parents in your hands.
Okay, ma'am.
Presentation, you can say it's a sickle cell disorder because the main presentation is pain crisis and chronic and transfusions. You cannot say sickle cell on history.
Okay, ma'am. Thanks.
And most of the time sickle cell have splenomegaly, which is not there in this case.
So what are the history and examination finding, Taral, would differentiate you, would let
In
you
sickle cell
differentiate?
anemia, madam, we may expect some splenomegaly, but mostly because of splenic asplenia, like splenic functional asplenia will be there due to the maybe splenic infarction and entrapment of RBCs will be there into the spleen. So might be the splenic infarction might be there, and that may cause the that spleen is not so big here.
Yeah. So basically, what we see in clinical practice that not all patients have a functional asplenia of the spleen. Even many
Yes.
patients with sickle thalassemia, they present with splenomegaly.
Splenomegaly. Yes, ma'am. That can be there. Yes.
For during the presence or absence of splenomegaly, we cannot differentiate among all those syndromes. For example, if it is a sickle cell thalassemia which has not undergone functional asplenia, the patient will present with splenomegaly.
Yes, ma'am. Yes, it can be there.
They also behave like thalassemia intermedia also.
Yes.
Any sickle
Yeah,
cell,
absolutely.
any combination of sickle cell can behave like sickle cell disease, or it can behave like thalassemia intermedia also.
Yeah, so organomegaly does not rules out one versus another, but
Yes.
organomegaly rules out that let us say if you have a massive splenomegaly, right? Then you look after the things related to massive splenomegaly, right? And then it is important. So my question to Taral was that in the
Yes.
history and examination, how would you differentiate intravascular versus extravascular hemolysis? Tell me
Okay, sir.
So I'm not going for investigation, okay? So don't tell me about the investigation finding. Clinically, how will you differentiate whether this child is having intravascular hemolysis or extravascular hemolysis?
So, sir, in the case of extravascular hemolysis, there is mostly presented with a hepatosplenomegaly, mostly splenomegaly. And in the intravascular hemolysis, patient may have a complaint of it's a hemoglobinuria. Red or cola colored urine was there.
And mostly it will be intravascular will be the acute onset,
yes,
most commonly, and this will be like it chronically we used to see
chronic.
extravascular and with the organomegaly, splenomegaly. Clinically, that we can just differentiate.
Yeah, and also the precipitating factors and all these things, right? Now,
Yes.
Yes.
what are the differential diagnoses of intravascular hemolysis, and what are the differential diagnoses of extravascular hemolysis?
Sir, in intravascular hemolysis, there is a differential diagnosis are ABO and RH incompatibility. and there is any history of mechanical trauma to the RBCs, like history of any valve prosthesis or recent any surgeries, and then any infection like Clostridium, then any drug exposure. Like quinine and sulfonamides, they all are causes the intravascular hemolysis. And for the extravascular hemolysis, there is a every hemoglobinopathy, enzymopathy, and membranopathies. They all are common under the extravascular hemolysis.
Where would you put autoimmune hemolytic anemia?
Sir, in autoimmune hemolytic anemia, it is a warm type of autoimmune hemolytic anemia is mostly extravascular, and cold type is both involve the extravascular and intravascular.
Yeah. So, what are the causes of infection which can lead to hemolytic anemia?
So, sir, infections like malaria, gram-positive organisms, then any leishmaniasis, toxoplasmosis, syphilis,
So,
more
what do you mean by
infectious
gram-positive?
mononucleosis.
Which gram-positive organism?
So, sir, in a gram-positive, there is a um, um, any staphylococcal or streptococcal infections, and they all are causing the infections, causing the hemolytic anemia.
Mycoplasma.
Yeah,
Yes,
mycoplasma.
mycoplasma.
And which other infection is known to cause hemolytic anemia apart from malaria and what you have described?
Then yes, sir.
Any anaerobic infections?
By it is a anaerobic
Clostridia.
Yeah,
Clostridium. I have already mentioned. Yes, Clostridium.
Right. Which are the drugs which can cause hemolytic anemia?
So drugs are any anti-malarial drugs like quinine and primaquine, then NSAIDs, then antimicrobial like penicillins and cephalosporins, and methyl dopa, levodopa, tetracycline, sulfonamides. It all causing the hemolytic anemia.
Anemia, which is more common in males.
Sorry, ma'am?
Any hemolytic anemia which is more common in males.
My
Anemia, you know, which is more
what
common.
what? Ma'am, I could not hear you
G6
properly.
Any
G6PD.
hemolytic which is
Acha,
more common.
G6. Okay, anemia. G6PD anemia deficiency.
So, how would you differentiate a case of hemoglobinopathy versus membranopathy versus enzymopathy in your clinical practice?
So, sir, in the case of
Because I
hemoglobinopathy,
am asking this question because based on that you are going to order the investigation, right? So why
yes,
this
sir.
patient? I am not discussing about the sickle cell disease. I am discussing the hemolytic anemia here. Okay.
Yes, sir.
So tell me
Yes.
what are the favoring findings of hemoglobinopathies? What could be the
Yes, sir.
favoring findings of G6PD deficiency? Or what
Yes,
could
sir.
be the favoring finding of hereditary spherocytosis? And if these
Yes,
things are
sir.
not there, then what are the negative findings? Why they are not there in the diagnosis?
So, sir, first of all, there's a hemoglobinopathies. In the case of hemoglobinopathies, they are mostly present after the 6 month of age, like thalassemia major and sickle cell and all that. Second cause is enzymopathy, G6PD. There is a significant history of drug exposure or not. So we can by that we can tell that about the enzymopathy, and it is a membranopathy. It is a hereditary spherocytosis, which associated with mild to moderate anemia, and later in onset in the age group, like after 2 to 3 years of age.
What very important history you missed in ruling out the membranopathy and enzymopathy? What is very important history as a general pediatrics you would never miss?
Antenatal,
The
Neonatal jaundice.
neonatal
neonatal jaundice,
jaundice. So
yes.
onset of the
And
jaundice
acute
is
onset,
very
yes,
important.
yes,
Yes. So
yes,
again, I'm telling you that you have to keep the thought process very open. Okay.
yes,
Right.
yes,
Like a G6PD deficiency can present in the neonatal age. Right. And then it can have a recurrent episodes whenever there is a crisis or whenever there is a
crisis,
stimulus. The same
yes,
thing sometimes happen to hereditary spherocytosis. Sometimes it can present early, sometimes it can present late. If it is a
yes,
a severe variety, then only it can present early. Otherwise, it can present even in adulthood age, right?
yes,
Okay, and
yes,
then the thalassemia usually does not present very commonly in the neonatal age. So they usually present
yes,
at 3 months or 4 months earliest,
yes,
right? And sickle
yes,
cell
sir.
anemia, if it is a homozygous sickle, it does not present within 1 year. It usually presents after 1 year, right?
Yes,
And
sir.
if it
Yes,
is a sickle cell with beta thalassemia, like what Dr. Gita was mentioning about the
yes,
spectrum of disorders which can mimic the thalassemia intermedia,
yes,
right? Those patients can present at 2 years of 3 years of age and all those things, right?
yes, sir.
And the second
Yes,
thing, when you are describing about chronic hemolytic anemia with
yes,
multi-system involvement,
yes, sir.
right? It is more likely to be a thalassemia or sickle cell anemia compared to G6PD or hereditary spherocytosis, because those patients
Yes, sir.
do not have multi-system involvement. Those patients do not have chest syndrome. Those patients do not have finger or joint swelling. Those patients do not have CNS symptoms or a recurrent hospitalization and all those things, right? Those patients are usually
Yes,
mild to moderate, and they do
yes,
not
sir.
visit you so often, right?
Yes,
But
sir. Yes, sir.
those are the important findings you need to describe, correct?
Yes, sir. Correct.
Yeah.
Yes.
Now,
So,
how will you investigate these type of patients?
So, sir, if a patient presented with any symptoms of like hemolytic features, like a patient presented with jaundice and splenomegaly. So, first of all, we have to go for the CBC with peripheral smear, and then other investigations include a reticulocyte count. Then it is a bilirubin level and LDH. Then other special investigations like heptoglobulin, and if it is a chronic in cause, and other if it is in the chronic in course, then we have to go for if a hemolytic phases and other are present, then we have to go for the long bones X-rays, and that we have to go for.
what the first investigation you would like to do? Patient has no money. Which investigation would you like to do first?
So first of all, ma'am, complete blood count with peripheral smear.
So with this history, if there is no money, we can go for directly HPLC.
So, did this patient had HPLC with you, with them?
I think
Yes, sir.
Can you show the finding of HPLC?
Yes, sir.
Can you read out?
Yes, sir. It is a HB adult is 6.3%. HBF fetal hemoglobin is 11%, 11.4%. HbA2 is 7.6%, and HbS is 67.1%. So values of hemoglobin study suggestive of sickle beta thalassemia.
why you are calling sickle beta thalassemia?
No, sir, I just read out the reports only.
No, but you must have read, right? That what is sickle beta thalassemia and what is sickle cell disease and all.
So,
So on
There's
this
increase in
Yes, can
HBS as well. A2.
okay. So what is HbA2 in sickle cell disease and what is HbA2 in sickle thalassemia?
in sickle cell disease, HbA2 is around
Usually absent.
Increased or decreased?
It is like it in
Will
case of
it-
sickle cell only, sickle cell anemia, that should be more than 50% HBS. And if
50%
it's
HbS.
thalassemia, then HbA2 level should be like more than 3.5. Here there is 7.6. So that's why it is a sickle cell beta thalassemia.
Does it confirm sickle cell beta thalassemia? Do you know anything about falsely elevated HbA2 and or falsely low HbA2? So what are the conditions that cause falsely elevated HbA2?
Falsely HbA2 after the recent any blood transfusion.
Yes. Yes.
What other common condition that leads to falsely elevated HbA2?
Falsely other condition I don't know. Ma'am.
So if you do not know the parents report and this is the HPLC report,
Yeah.
right? So would you consider it directly as sickle beta thalassemia, or would you like to rule out anything else which is going on?
So if this is the first reports if we have, and so we will see the age of patient, and if the age is like more than 10 years, we will advise to go for the parental evaluation. Parents HbA1c is important.
So parents HPLC is important. In this case, we know beforehand that the mother is sickle or one parent is sickle and other person is thel. But usually, we seek falsely elevated HbA2 in cases of megaloblastic anemia.
Okay.
Okay.
And as we discussed earlier, also this is a patient with pure vegetarian diet, probably adolescent, must be having some food taboos and all. And he has a status where the required turnover is high. So he's a candidate of proper megaloblastic anemia.
Yes. Yes. Yes.
Rated in megaloblastic anemia also.
Yeah.
So this is also important when you conclude an HB electrophoresis report, because if for example sickle is not there and HbA2 is high and no sickle is present, so what would you say? What would you say to the patient? What would be the diagnosis? If HbS is 0.
HbS is 0 and HbA2 is high, then it might. Okay. So it might be any sickle cell.
More likely thalassemia.
Which thalassemia?
Thalassemia intermedia.
Thalassemia intermedia.
Thalassemia intermedia will be there.
So HbF is also normal. HbA is also close to the normal range. There is no sickle, and HB is high.
Which HB is high, ma'am?
HbA2.
So fetal hemoglobin we need to
Fetal.
check. No? What is the fetal hemoglobin?
Normal. I'm saying HbF is also normal. Only HbF is high, and there is no other abnormal hemoglobin found in electrophoresis.
Hell
Okay,
minor.
then, like in case of hyperthyroidism or this vitamin B12 folic acid deficiency of child is on some ART, then also there will be a falsely high HbA2 and other parameters will be normal.
So basically, it could be a case of thalassemia minor, but we have to rule out all other things, especially B12 deficiency, which is very common in Gujarat because majority
Yes.
of them are vegetarians. So before you mention the person to be a thalassemia minor, we have to check all this because when you state a patient or a person to be a thalassemia minor, it's a lifelong thing. It's going to stay with the person, and it has long term implications in terms of marriage and future childbearing also, right?
Yes, ma'am.
Yes, sir.
So what else reports now you will do? HbS is 67.1. What other thing would you like to rule out in this patients? For example, if HbS is 30,
Yes,
HbS is 40 and patient has anemia,
yes,
right? History of pain crisis and all. So what other would like to rule out?
Other abnormal like HbSC or those type of abnormal hemoglobins.
Yes.
yes,
Patient has
Other
present
type of
patient has presented with classical crisis. Okay.
yes,
And HbF is not very high and HbS is also less than 50, but you are suspecting sickle.
yes.
So what history would you like to ask?
Uh,
Any acute stress event, infections, dehydration.
No, in dehydration also HbS will increase. So see, whenever you see the report, now you have put the report here only in the slide. Whenever there is a report of hemoglobin electrophoresis, it says kindly correlate with clinical status and history of blood transfusion.
yes,
So what would you ask? You will ask at what time the
Blood
last
transfusion. BT was
taken. So because whenever you give blood transfusion and then check the HB electrophoresis, it is only the HB electrophoresis of donor's blood and not the recipient's blood, right?
yes,
Patient might have sickle cell disorder, but because of recent transfusion, the HbS level is low.
low. Yes,
In that case,
yes,
if you are suspecting sickle cell disease, what would be the next step you will do? You are suspecting it's a sickle cell disease only. The patient has got recent transfusions. What will you do?
sickling test.
Sickling test would be positive because if there is HbS is present, sickling test is positive.
Then we actually wait for 3
HB.
months, ma'am, and repeat HB electrophoresis.
Yes. Or other thing, what you can do is you have parents with you, right? You can check HB electrophoresis of parents.
Parents.
yes.
Yes. If one parent is sickle, another parent is thal, or if both parents are sickle, there are more chances that the patient is having sickle.
Disease.
This is.
Hmm? And even if both parents are sickle trait, or one parent is sickle, another parent is thal, what are the percentage of chances that the next pregnancy in next pregnancy mother is going to harbor again a child with disease, because this is very important.
25%.
25%.
25% would be disease.
This is 25% would be no.
Disease.
25% disease.
25 normal
25%
and
will be
50% are
thalassemia
carried.
trait. 25% will be sickle
Yes.
trait and
Sickle cell
25%
trait
normal.
is
Yes.
normal. Yes.
Okay, and if suppose parents are planning next child, then what would you counsel the parents?
So, if it is counsel for the, and if both parents are trained, there we have to counsel about the chances of transmission of the disease and being normal and carriers in the child. Then second thing, we have to
So mothers
counsel about.
are saying you that we are planning next pregnancy. We are
Yes, ma'am.
planning conception. What would you suggest to the parents?
It is a
Ma'am, they can do a
prenatal.
whole exome sequence of the amniotic fluid to see for the mutation.
So you will do whole amniotic whole exome sequencing of fetus.
Either a non-invasive that NIPT, ma'am, cell-free fetal DNA, or
NIPT.
the
So what the first test would you do right now? You don't have fetus right now. What test would you do right away? Because if mother gets pregnant and she got another sickle cell child, the onus will be on you because you were the treating doctor
So
for
we
this.
can advise non-invasive prenatal testing.
But before that, what will you do? So you will advise antenatal testing, but what will you check in that antenatal testing?
For advice for HbA HbA2
Of
of
fetal.
mother, fetal
embryo.
fetal blood
sampling.
cell.
So see, we will do antenatal testing of fetus, and we'll do
Yes.
genetic testing of the fetus. But whenever we do genetic testing of a fetus, it is a targeted testing, right? So
Yes.
you have to find out whether the abnormal genes are present in the fetus or not, which are there in the child. Okay, primary you have. So what you
Yes.
will do is firstly you will do the genetic testing of this child.
Yes.
So you for hemoglobinopathy screening genetic testing for this child, and you will find the abnormal mutations. Okay, so there in
Yes.
this child there will be two abnormal mutations. One would be a sickle mutation, and another would be a thal mutation. Right
Yes.
now, when you have testing of this child in hand, this child in your hand, then in the next pregnancy you can do amniotic testing and you will check only these two mutations,
Yes.
because that and then next child is going to be a genetic mixture of parents only. Both have common genes. Next child is to have the common genetic material of the parents. So if both mutations are present, what will you suggest?
Termination, MTP.
And if one mutation is present, what will you suggest?
And it is a continue the pregnancy and tell the parents about the chances of transmission in the child.
Then the child will be a trait, ma'am. Trait.
So if only one mutation is present, either sickle or thal, then they can continue
Continue
pregnancy.
the pregnancy.
The child
Yes,
will
it
be
is like so. In such condition, there is a trait. So we need to counsel the parents before the continuation of the pregnancy because they are expecting the child with third sickle cell trait. So counseling is necessary.
but in this case you will not you will not explain them termination because the carrier
Yes.
usually normal life.
Yes.
So that like their parents only. तो आप ऐसा कह सकते हो कि ये बच्चा जो है इसको सिकल ट्रेट है या थैलेसीमिया ट्रेट है, बट इसका लाइफ आप लोग जैसा ही होने वाला है जैसा आप लोगों का है.
Yes.
Okay, Dr. Chintan, you can ask something if you want.
So how
Hello?
will you treat the child?
Yes, sir.
How will you treat the child?
So, sir, first of all, if sir, matlab in this case, if a child present with the chest pain and all that, so first of all, I want to measure the vitals. After that, proper oxygenation, then pain management by NSAIDs. After that, if we are suspecting any hemoglobinopathy for this patient, then we have to start for the antibiotics, and we have to
So
check
whenever
for the
I ask this,
hemoglobin.
whenever
And
I ask the question, Taral, you have to listen what I'm asking. I'm asking how will you treat this child? I'm not asking how will you treat a child of sickle cell disease. I'm asking this child is sitting in your OPD. What prescription will you write for this child? Okay. And then I will ask the different scenario, and then how will you treat that
Hydroxyurea.
child?
So myelosuppressive agent hydroxyurea should be started as early as
Yes.
possible when we get the diagnosis, so first time diagnosis.
Yeah, so that is one, right?
To
Now,
start,
yes,
yeah. Would you like to do some other basic investigations?
Yes, yes, ma'am. If the child is now 16-year-old, then we want to just check for the cranial Doppler study to check for the possibility of stroke.
Endocrine workup also.
Yes,
so first
endocrine
of all,
workup.
yeah,
yes,
so first of all, we have to go very methodically. Okay.
Basic.
When you are asking for, when you are sitting in OPD, right? The treatment means investigation and treatment. Okay. Management
yes,
means investigation and treatment. So whenever you are seeing this patient, you will like to first see the CBC, right? The
CBC,
liver
yes,
function test and kidney function test. That all other tests are normal because this
yes,
child has multi-system disorders. You would like to see is there any other problems of apart from hyperbilirubinemia. What are other things in liver and what are other things in kidney? If the B1 creatinine is normal or something like that. Okay, that is first
yes,
thing. Second thing, that when you know the diagnosis, this patient is having sickle cell disease. Okay,
yes, yes,
when you know that this patient is
yes, sir. Hello.
yeah, sorry, you can know whether the child is on any medication like folic acid or calcium or multivitamins and all those things, right?
Yes,
That you need to see whether this child is on these medicines. Okay,
yes,
then you need to see whether the child is receiving hydroxyurea already or not. If the child is
yes,
receiving hydroxyurea,
hmm,
if the child is receiving hydroxyurea, you
yes,
need to
sir.
see
Yes, sir.
what is the dose of the hydroxyurea. Okay,
Yes,
whether it is going in a correct dose or not. And then
yes,
what are the subtle features which can tell you whether your hydroxyurea is working or not, right? So particularly you
yes.
see MCV, mean corpuscular volume,
MC,
right?
yes,
Yeah,
yes,
so if that is suggesting that your hydroxyurea is working or not, and what is the compliance
yes,
of the patient for the
yes,
hydroxyurea, whether it is taking daily, regularly, not, whether it is taking only in the times of crisis, and all these things, right? And what is the
yes,
dose
sir.
of the hydroxyurea which is going on? And then you need to know whether we can increase the dose, whether we can reduce the dose. But before that,
Yes,
you
sir.
need to know your liver and kidney function test, okay?
Yes, sir.
And
Yes,
baseline WBC. And once you start
yes,
the patient, if the patient is not on hydroxyurea, you start the patient on low dose hydroxyurea first, 20 milligram per kg per day,
yes,
and then you go
per
up
day.
to 30
Yes,
milligram per kg per day,
30.
which is
Yes,
like a maximum tolerable dose in an Indian
yes,
setting, right? And then you in
yes,
between 20 to 30, you juggle the dose based on your weight and your WBC count and liver function and kidney functions, right? And these are
yes,
the things. This is the management of sickle cell anemia sitting in your OPD. Now, when the sickle
yes,
cell anemia comes into your emergency, right?
yes,
That time you
yes.
need to make sure your vitals are good. Okay, your oxygenation is
Okay.
good, your hydration is very good. Your
Yes,
patient has to have a good hydration.
yes,
If not, you have to start the patient on hyperhydration or at least 1.5 times of the maintenance. You need to check the
yes,
patient has received blood transfusion in the past. If not,
yes,
you have to immediately arrange for the blood to keep the hemoglobin at
yes.
least between 8 to 10, not less than 8
8
and
to
not
10.
more than 10. Okay.
Okay. Yes.
And then you need to do your baseline chest X-ray to see is there any consolidation or patch or anything, and you need to rule out any other infections by doing CRP and blood culture. Okay.
Yes.
If the patient
Yes.
is having any infective episodes. And
Yes.
then at the same time, when you are having a patient with crisis, you need to know what is your sickle percentage at that particular time. Okay. If your
Yes.
sickle percentage is high and if the patient is in crisis, you need to manage
Yes.
the crisis by doing either hyperhydration and blood transfusion,
Hyperhidrosis.
because
Yes.
in the case of in the time of crisis, your hydroxyurea will not work, right? It's a medication
Yes.
to keep the disease in a chronic stable condition, but it will not work in an acute condition. You have to
Yes.
manage either with good hydration, good blood transfusion, not overzealous transfusion, but a good blood transfusion.
Yes.
Sometimes you have to do a exchange transfusion
Exchange
in that
trans.
scenario,
Exchange
Yes.
right?
transfusion.
Yeah,
Mm,
exchange
yes.
transfusion, and then you need to monitor very closely this patient, that whether your HPLC, whether your sickle cell percentages are coming. So whatever is, let us say if your sickle percentage is 60%, if your patient is in crisis, you would like to bring down to less than 30% by doing all this
Yes.
measure. Okay,
Yes.
this is the
Yes.
way you manage the patient in crisis. And now the
Right.
last question: what is
Yes.
an long-term cure for sickle cell disease?
So in long-term
Stem
cure is
cell
a
transplant.
hematopoietic stem cell transplantation.
So before going for before asking the patient to go for hematopoietic stem cell transplantation, what would you make sure that this patient has received?
Sorry, sir, I couldn't understand your question.
So
Before?
hematopoietic stem cell
Immunization.
transplant is the not immunization, but hematopoietic stem cell transplantation is the definitive cure, correct?
Yes, sir.
But
Yes,
not
sir.
in all patients, right?
Yes, sir.
Only few
Uh,
patients require hematopoietic stem cell
okay,
transplant
sir.
in sickle beta thalassemia,
Okay, sir. So, sir, we
right?
have to ask for, yes, sir.
So
So,
what
sir,
are the questions and what are the points you will write in your prescription? This will
yes,
define the indication of this patient should be referred
okay,
to
sir.
a transplanter or
Yes,
cannot be referred to a transplanter, or should be a
yes,
discussion with the patient. So there are three scenarios. One thing is you are a general
yes,
practitioner, okay,
yes, sir.
and you
Yes,
are seeing this patient and you will only decide that this patient will require transplant or not. Okay,
yes, sir.
that is very
Yes, sir.
difficult at your level, but you still can decide. Second
Yes,
thing,
yes,
you are
sir.
dicey, you are confused, you have not too much of experience of sickle cell disease, so you refer to a hematologist, experienced hematologist, and they will decide whether this patient will require a stem cell transplant or not. Okay,
Yes, sir.
and
Yes, sir.
in certain cases where you know that this patient, in by seeing the by having minimum of knowledge of sickle cell disease in Indian scenario, you will tell no, this patient is not a qualification for a stem cell transplant, right? So in these three scenarios, would you choose? Would you as a general pediatrician, or I want
General
to ask to a
pediatrician.
pediatric panel also sitting in the in this presentation,
Okay.
what a general
Okay.
pediatrician
So,
So,
sir, if
feel, that are they confident enough in ruling out the patient being stem cell transplant indication, or they are not confident, first of all, and secondly, if they are not confident, at what stage they would like to refer this patient to a hematologist who can be definitely confident that this patient will require stem cell transplant or not before they refer to us, before they refer to me
yes,
for stem cell transplant.
yes,
The
sir.
hematologist will definitely filter it out. Dr.
Yes, sir.
Geeta will definitely filter it out. But as a
Yes,
general pediatric level,
yes.
how would you approach?
So, sir, if any patient had a history of stroke, if patient had repeated episode of the painful crisis for which he required the hospitalization, more than 3 times in a year, then there is a patient is repeated episode of the crisis, history of the stroke, and history of the rate
blood
of
transfusion.
hospitalization, blood transfusion.
Requirement of
Required
repeatedly blood transfusion.
blood
If it
transfusion.
is increased, so total three criteria. On the basis of these three criteria: acute chest syndrome, sickle cell crisis, and requirement
Yes,
of recurrent blood
blood
transfusions,
transfusion.
we can decide that this under stroke. So we can decide on the basis of these four criteria that stem cell is required or not.
Any other general pediatric practitioners would like to add on this patient? He's a 16-year-old boy. Before referring this patient to a hematologist, and before hematologist refer this patient to me for a transplant.
If the
See
child is
for the
not
endocrine
responding,
profile.
not responding with the hydroxyurea, with the maximum
Yes.
hydroxyurea dose, if the child is
Yes.
getting all ACS or crisis and strokes and recurrent blood transfusions, then we can advise.
Right. What else? He's a 16-year-old boy.
So if any associated with any endocrinal dysfunction patient.
Yes, other complication like
Other
hypogonadism.
complications like
So for the
hypogonadism,
transplant, for
hypopituitarism.
the stem cell transplant, what do you need? Can it be autologous or allogenic?
Okay, sir. It is
Do you know what is autologous and what is allogenic?
yes, sir. Autologous is from the another donor person.
Auto means
Autologous
self.
is the same individual, obtained from
Sorry,
the same
sorry,
individual.
sir.
Auto
I
is
missed.
self.
Same individual, and allo is another.
Auto is self and allo is a different.
Is a
So
different.
this
Sorry.
patient
Yes.
will qualify for autologous transplant or allogenic transplant?
I don't know, sir.
Hello.
Analogous HLA matched donor we want.
So this patient will qualify allogenic transplant, okay, not autologous.
Yeah. Okay.
Right, first of all, because autologous is this patient hemoglobin is already defective, this patient is gene is already defective. So you are
Yes.
not going to do autologous. So you for allogenic transplant, what do you need?
Donor. We have donor.
Donor. So from where the donor will come?
So, sir, any siblings?
Right.
Children?
So the
Yes,
first
sibling.
question will you ask that does this patient has a sibling or not?
Yes.
Then second question you will ask is there any sibling 100% HLA match with this patient or not?
Yes, sir.
What are the probability of sibling match? So that you may not answer, but I'll answer for you. It is 25% with each pregnancy. Okay.
Okay.
25% chance of getting sibling match with each pregnancy.
Yes.
Right. So
Yes.
if you have a sibling match, you can still debate and discuss about the transplant. But if you do not have a sibling match, you should
Okay.
refer this patient for a hematologist opinion, and he or she will decide whether this patient will be referred to me or not.
Yes, sir.
Correct. So that is first and foremost. The second
Yes.
important thing is age. So what age are you transplanting? Are you too late to transplant or even offer a patient to transplant, or you are still in a good age for a transplant? You may get a patient of 32-year-old with thalassemia. Will you refer that patient for transplant? Right? You may get a 20-year-old sickler also. Will you refer that patient for a transplant, or you will see what is the age of the patient? Third thing comes the severity of the symptoms, right? So first is donor availability. Second is
Donor.
age of the patient.
Age.
Ideal age of the patient of a transplant for sickle cell anemia is 16 years. So your
16.
patient is just at the borderline. Okay.
Yes, sir.
And then you see the severity of symptoms. So severity of symptoms also, if you have any episode of stroke, which you have mentioned rightly, if you have a transcranial Doppler velocity of more than 200 milliseconds,
200.
if you have a recurrent chest syndrome more than 3 episodes per year or more than 4 episodes per year, in spite of having best supportive care, blood transfusion policies, as well as hydroxyurea with adequate dose and compliance.
Yes.
Okay. If you have a recurrent painful crisis requiring multiple hospitalization more than 3 episodes per year. Okay. If you have avascular necrosis of the hip joint, right, which is still not like a grade 4, but a grade 1 or 2 this thing. If you have an acute or chronic lung disease, which is still between grade 1 and grade 2, it is not stage 3 or stage 4 lung disease where you are ventilator dependent. Okay. Stage 4 lung disease or stage 3 lung disease means you are oxygen dependent, you are on home ventilation, and you are not able to maintain your oxygen. So that stage you are not going for transplant. If you have a proteinuria but your kidney disease, is still in the GFR of means your kidney disease is still stage 1 and stage 2. In the stage 3 and stage 4, where your GFR has dropped less than 50, you are not going for stem cell transplant. So stage 1 and stage 2. If you have a retinopathy, okay,
Yes.
if you have a retinopathy, that is, if you have a recurrent priapism, that is an indication, right?
Yes.
And any episode of stroke, as you have mentioned, okay?
Yes.
Or if you have a multiple requiring transfusion, making the patient alloimmunized and causing frequent transfusion related complications, okay? Those are the patients where you need a transplant indication, okay? But all these indications are good if the patient's age is less than 16 years and if the patient has a match sibling donor, 100% match sibling donor available. If the patient does not fit into 16 years of age or less than 16 years of age with any of these symptoms, it is purely an experimental therapy which has to be discussed 1:1 with consideration with the expert hematologist opinion. And after expert hematologist opinion, it has to be referred to a transplant center which has to have an experience of doing transplantation in sickle cell disease.
Yes.
That too alternative donor transplant like half match transplant or unrelated donor transplant. Then only with the patient's choice, purely the patient's choice, you can go for a stem cell transplant as an alternative donor, which is half match transplant or an unrelated donor transplant. So this is just a brief overview that where will you refer your patient for a curative treatment, which is stem cell transplant. Okay, the more you, the later age, the results of stem cell transplant are not good. The alternative donor transplant, the results are not good. Okay, so that is very important. So as I have told you, if I see the thalassemia patient, I counsel 100% of my thalassemia patient for transplant, 100%. Right? And Dr. Geeta will also agree that all thalassemia patients should be counseled for the transplant because there is no other alternative cure for thalassemia. But if we are discussing sickle cell disease, 1 in 10,000 or 1 in 20,000 Indian sickle cell patient will be counseled for transplant. 19,000 patient will not be counted. 19,990 patient will not be counseled for transplant because they are not sick. They are not compliant also to hydroxyurea. They are not compliant to blood transfusion therapy. Also, okay. So all these things are there, which is which makes your transplant indication in a question mark. We are not sitting in Europe or America where everything is absolutely up to the mark. And then you counsel the patient, then you follow this criteria of more than 3 episodes per year, any episode of stroke, any episode of chest, more than 3 episodes of chest crisis. If the patient has not taken hydroxyurea for 6 months, you are bound to get chest syndrome. They're bound to get vasopressor crisis, right? If the patient is not taking adequate dose of hydroxyurea, you are bound to get symptoms, right? If the patient has failed hydroxyurea, and if the patient has not gone on to transfusion regimen, which is the second best option for sickle cell disease, after transfusion, after hydroxyurea, the second best option is a regular transfusion therapy. If the patient has not received regular transfusion therapy, then also it is not a candidate for transplant, correct? But it is very important when to refer the transplant. If you have a match sibling donor, if the patient is well educated, if the patient has followed up all the criteria, if the patient has taken at least 6 months or 1 year or 2 years of trial of hydroxyurea, patient has already taken the transfusion therapy also, at least 70-80% of the expected. And then you refer the patient to a hematologist and we can do the transplant because it's a match sibling donor transplant. The cost is less, the complications are less. Okay, right? So do not refuse the patient for transplant also, right? If you are deserving, but do not tell that the sickle cell disease is a transplant indication, right? You have rightly mentioned the indications, but the indications are very important where to apply those indications, right? So sahi patient ko identify karna, that is most important, okay? Not to delay the transplant till the 16 year of age. If the patient comes at 10 years of age, and if you are having already failed hydroxyurea, failed transfusion program, and if you have if you have done the HLA typing, you should do the HLA typing. And if you have identified the patient with a match sibling donor, do not delay. Refer that patient at 10 years of age or 7 years of age or 8 years of age. Do not delay for more than a year or at least, right? Because more the delay, the less will be
Yes.
the outcome of thalassemia,
Yes.
sickle cell disease transplant.
So basically, in medicine, the thumb rule is that you have to always
Yeah,
Yes.
Dr. Geeta's opinion on this.
basic rule of medicine is that whenever you take a decision for a patient, you have to always assess a risk benefit ratio. Correct. So if it is a routine sickler going well on hydroxyurea, the risk is very high for transplant. But if it is a complicated sickler not going good on hydroxyurea, then benefits are much more than the risk. So basically, just last question. You have prescribed hydroxyurea to the patient, right?
Yes.
Will prescribe, I think so, Hana? And you will check the nutritional whether he is iron or B12 deficient or all. Because as a thumb rule, कोई भी एनीमिया आपको दिखता, कोई भी एनीमिया है ना, तो आपको न्यूट्रिशनल कंपोनेंट जो है वो एनी हिमोलिटिक एनीमिया न्यूट्रिशनल कंपोनेंट यू हैव टू मेक श्योर
Yes.
राइट न्यूट्रिशनल
Yes.
का डेफिशिएंसी है, you should correct it because in any hemolytic anemia we try to keep a good target ताकि कभी भी hemolysis जो ड्रॉप हो वो बहुत ज्यादा सिग्निफिकेंट ना हो. ठीक है, तो इन आयरन B12 स्टेटस एक बार देखना जरूरी है एंड करेक्ट करना जरूरी है एंड टू सी कि पेशेंट का न्यूट्रिशनल स्टेटस करेक्ट करने के बाद मैक्सिमम हीमोग्लोबिन क्या है. ठीक है,
Yes.
आपने हाइड्रोक्सी प्रिस्क्राइब कर दिया, फॉर एग्जांपल आयरन B12 फॉलिक एसिड स्टार्ट कर दिया, आयरन B12 जो डेफिशिएंट था वो आपने करेक्ट कर दिया. अब आप पेशेंट को क्या बोलोगे कि क्या होगा तो आप मेरे पास आना, और कब आना हाइड्रोक्सीयूरिया स्टार्ट करके?
It's after starting the after.
टेल सम डेंजर साइंस टू द पेशेंट कि ऐसा ऐसा हो तो आपको हॉस्पिटल में रिपोर्ट करना है.
If a patient had a then any illness or high grade fever and any symptoms of any crisis, then the patient have to report to the hospital.
Come to the hospital in case of high grade fever. Routine viral fevers are very common. I think you must also be seeing in your
Yes.
OPDs.
Yes, ma'am.
But viral fever, high grade, 103, 104.
Yes, ma'am.
Why would you say in this case to come to the hospital if they have high grade fever?
The patient have any
Because of
symptoms of crisis?
because sometimes in sickle cell anemia they will not present with fever, so underlying sepsis might be there. So for that we need to evaluate, or any single fever also we need to take for the evaluation and treat aggressively.
So basically, you have already mentioned that patient has small spleen. So already he has aspleenia. In most of the cases, even if the patient has normal spleen size or splenomegaly, also these patients have functional asplenemia, right?
Yes, low immune status
Yes,
will be
low
there.
immune.
Sicklers are basically immunodeficient patients.
Yes.
So whenever a patient has immunodeficiency, we have to be very vigilant if they get any fever, because there are high chances that even if it is bacterial, they are prone to have significant septicemia and may end up in septic shock. So threshold of antibiotics we have to keep low in that patient. So yes, जब भी high grade fever होगा तो आप patient को बोलोगे कि you have to report to the hospital. Right? और बाकी और किस चीज में आप कहोगे कि ऐसा हो जाए तो आपको हॉस्पिटल आना ही है?
If ma'am, any other symptoms of any crisis, like sickle cell crisis symptom, like breathing problem, where patient had a severe chest pain or any symptoms of vaso-occlusive crisis, so we have to adjust the dose of the hydroxyurea in these cases.
Yes.
So we have to tell the patient.
ठीक है, तो पेशेंट को थोड़ा सा दर्द हुआ, घर पे थोड़ा सा दर्द हुआ तो वो उसको आ जाना चाहिए हॉस्पिटल?
No, sir, ma'am, we have to explain about the severity of the disease to the patient and evaluate accordingly.
So basically what we do what you have to do is pain crisis is the most common crisis in sickle, right?
Yes.
So you don't want to be your OPD also,
Yes.
है ना? So you have to explain them कि अगर थोड़ा पेन
Yes.
होता है take this medicine, उससे थोड़ा ज्यादा होता है तो you take one more medicine, उससे भी नहीं ठीक होता है और बहुत ज्यादा तकलीफ हो then you report to the hospital. हाँ, उसके लिए एक पेन स्केल भी होता है. There is some wrong
Wong
bank.
Baker. Yes,
Wrong,
Wong Baker pain
wrong
scale.
maker faces.
दे सकते हो और आप उनको बोल सकते हो असेस करने के लिए कि आप एक गोली लो, राइट योर स्कोर, है ना? देन रीइवैल्यूएट योर स्कोर आफ्टर 30 to 45 minutes, or if the score is increasing you report to the hospital. If the score is decreasing you can go home, get hydrated and manage at home only, है ना?
Yes.
और क्या होगा पेशेंट को आप बोलोगे, बिकॉज दिस इज मोस्ट इम्पोर्टेंट. क्रोनिक तो आपने मैनेज कर दिया, आपने उनको दवाई लिख कर दे दिया एंड ही इज टेकिंग, बट if we are not able to manage emergencies, if they are not able to identify their emergencies, they may face some life threatening complications, right?
Yes, ma'am.
और कौन सा क्राइसिस होता है सिकल सेल में?
Ma'am, if any sequestration crisis hota hai, a patient present with severe abdominal pain, so we have to patient को बोलना चाहिए. दूसरा एक if any suspected stroke features like severe headache and weakness in the limbs, we are suspected there. Then in the case of priapism and so in this all crisis we have to call the patient or the hospital.
अच्छा, एक जनरल इंस्ट्रक्शन आप क्या हर सिकल वाले पेशेंट को एक जनरल इंस्ट्रक्शन आप क्या बोलोगे? रूटीन, बच्चा है, स्कूल जाता है, एडोलोसेंट है, तो शायद कॉलेज जाता होगा, ट्यूशन जाता होगा, आप क्या बोलोगे कि इस चीज का ध्यान रखना, और पेरेंट्स को भी बोलोगे इस चीज का ध्यान रखना?
So we avoid any strenuous exercise and avoid the prolonged hours of swimming because it lead to increase and hydration. Mean first
Hydration, status of
hydration
hydration.
status of the patient.
हाँ, तो ये बहुत इंपॉर्टेंट है. व्हाट वी से टू आवर सिकलर्स, जहां पर भी जाएं अपना पानी का बॉटल या कोई भी लिक्विड जो है साथ में लेके जाएं. वी डोंट हैव एनी सिकलर पेशेंट बॉटल के बिना एंटर करता हो ओपीडी में. ठीक है, तो हाइड्रेशन बहुत इंपॉर्टेंट है. एक सिंपल आपने एडिक्वेट पानी लिया है तो ऑफ द सिकल क्राइसिस जो है दे डू नॉट हैपन, एंड यू हैव टू टेल देम कि दे हैव रिलायंट ऑन हाइड्रोक्सीयूरिया. क्राइसिस में we do not change doses, and when you start hydroxyurea after how much time you will increase the dose?
4 weeks.
4 to 8 weeks. Yes.
Yeah, so usually we increase the dose after 6 to 8 weeks, and we'll have to check compliance. And as Dr. Chintan also rightly said, we have to look at MCV also, because whenever you give hydroxyurea, the MCV increases. But in this case, you will not. In this case, you will not be able to get a good rise in MCV. Can you tell me the reason why? आपका जो बच्चा है उसमें बहुत ज्यादा एमसीवी आपको बढ़ा हुआ देखने को नहीं मिलेगा.
Thalassemia trait is also there.
तो बिकॉज HBS थैलेसीमिया है तो उनमें यूजुअली माइक्रोसाइटोसिस होता है. आप इनका सीबीसी देखना जाके, उसको माइक्रोसाइटोसिस होगा मोस्टली, और वो कंपाउंडेड इफेक्ट होगा थैलेसीमिया का भी और आयरन डेफिशिएंसी एनीमिया का भी. तो इस केस में आपको कैसे पता चलेगा वेदर योर हाइड्रोक्सीयूरिया इज वर्किंग और नॉट?
The level of sickle HB will also give us some idea about that.
So usually we check HB electrophoresis after 6 to 12 months of starting. But before going on any investigation, है ना, because every investigation has a cost. हाँ, तो उसके पहले आपको क्लिनिकली देखना है कि पेशेंट रिस्पॉन्ड कर रहा है कि नहीं कर रहा है. तो क्लिनिकली आप कैसे देखोगे? यू हैव टू टेल योर पेशेंट टू मेंटेन रिकॉर्ड्स ऑफ देयर वीनो ऑक्लूसिव क्राइसिस, है ना. साल में जैसे पहले आपको डॉक्टर चिंतन ने अभी बोला था कि कितने एपिसोड्स हुए, कितना दवाई से ठीक हुआ, हॉस्पिटलाइजेशन लगा कि नहीं, ओरल से ठीक हो गया कि आईवी से ठीक हो गया. तो बिफोर स्टार्टिंग हाइड्रोक्सीयूरिया एंड आफ्टर स्टार्टिंग हाइड्रोक्सीयूरिया, और यू कैन हैव दैट रिकॉर्ड्स कि स्टार्ट करने से पहले 5 बार उसको होता था साल में, अभी 1 या 2 बार ही होता है. तो इनडायरेक्टली इट इज टेलिंग दैट योर हाइड्रोक्सीयूरिया इज वर्किंग, राइट. तो ऐसे केसेस में है ना, मेंटेनेंस ऑफ रिकॉर्ड्स इज आल्सो वेरी इंपॉर्टेंट. वी डू टेल आवर पेशेंट्स टू मेंटेन द रिकॉर्ड्स ऑफ देयर पेन क्राइसिस एंड आल्सो द रिकॉर्ड्स ऑफ ट्रांसफ्यूजन, है ना. हाइड्रोक्सीयूरिया इनडायरेक्टली हीमोग्लोबिन भी बढ़ाता है, एचबीएफ बढ़ा के. तो आपका रिक्वायरमेंट ऑफ ट्रांसफ्यूजन भी कम हो जाता है. तो बिफोर एंड आफ्टर का रिकॉर्ड्स चेक करके यू कैन सी क्लिनिकली आल्सो दैट योर हाइड्रोक्सीयूरिया इज वर्किंग. और फिर बाद में एमसीवी, increase in MCV, increase in HbF, decrease in HbS will give you further objective evidence that your hydroxyurea is working, right? And when will you stop hydroxyurea?
If we get the sign of bone marrow suppression, sir, then we will stop.
So usually when platelet count is less than 80,000 to 1 lakh, or TLC falls below 3,000, we stop hydroxyurea. And this is the reason
Yes.
why we monitor. So whenever we increase the dose, we have to call the patient after 4 to 6 weeks to check for neutropenia, thrombocytopenia.
Neutropenia.
And what other systems does hydroxyurea affect?
It is a liver and kidney.
So that's why it is also important that before you start hydroxyurea, you have to document a baseline SGPT creatinine. So if there is increase in SGPT or creatinine 2 to 3 times the baseline, it is probably an indication to stop hydroxyurea.
Sorry.
So you have to document the baseline SGPT and creatinine.
Yes,
So
ma'am.
starting hydroxyurea, so that when you repeat the test, if it is 2 to 3 times more than the baseline, it is probably an indication to stop hydroxyurea. Okay.
Yes, ma'am.
I think Dr. Chintan, you want to ask anything else?
So just last question, that does sickle beta thalassemia makes the child better than sickle cell disease? Is the addition of beta thalassemia in sickle cell spectrum makes the
Yes.
life easy or bad? Change. Hello,
Hello.
did you hear my question?
Yes, sir.
Hmm.
Sir, it improve the life.
Why?
Because sir, in sickle cell disease, there is a more chances of the crisis and
Why?
so
Why? Homozygosity.
it is due
There is
to
a beta component, right? And what is the role of hydroxyurea? What does hydroxyurea do?
So actually, in case of sickle cell, there will be HbF2 level will be also high. So affinity of oxygen affinity will be high as compared to sickle cell disease patient. So there will be less chances of vaso-occlusive events or hypoxic stress induced hemolysis in case sickle cell as compared to sickle cell disease. So sickle cell will be
Right.
the better.
Yeah, because hydroxyurea also ultimately does the same thing, right?
Yes, yes.
Hmm?
So
It also
hydroxyurea is have two mechanisms. One is that that will bind to the hemoglobin and increase the affinity of the hemoglobin to bind with the oxygen. And one more is that increase the production of nitrous oxide, so that vaso-occlusive events will be less with the hydroxyurea. This is the main two mechanism of action of
Yeah.
hydroxyurea.
So basically, and then third thing, very important, that why we
Fetal
are worrying
hemoglobin
about.
production.
Sorry.
And important mechanism is fetal hemoglobin production in sickle
Correct.
cell
Fetal hemoglobin
for
production. That is what I was
hydroxyurea.
trying to comment. It increases the fetal hemoglobin production, and that is why
Yes.
adding beta thalassemia, which already increases the fetal hemoglobin, is win-win scenario. Correct. And
Yes.
very important thing is that hydroxyurea also reduce your neutrophil numbers. And the crisis of sickle cell disease is not just because of the red blood cell. It also attracts a lot of neutrophils at your crisis site, and that will increase your this thing activating factors, cytokines, and all, and that ultimately lead to clogging of the vessels. So in a way, hydroxyurea reduce your neutrophils, your neutrophil function, neutrophil attachment with the vessels, राइट और उसी से फिर उसका न्यूट्रोपीनिया होता है तो हमें साइड इफेक्ट ज्यादा लगता है उसका. सो वो
Yes.
न्यूट्रोफिल का जो एक्टिवेशन है वो कम करता है, और उसकी वजह से जो न्यूट्रोफिल एक्टिवेशन होने के बाद जो जो क्लॉगिंग होता है वेसल्स में, सो the crisis is not only because of the altered red blood cell. Crisis is happens also, the neutrophil also contribute to the crisis, and hydroxyurea reduce the neutrophil activation.
Yes.
Right? है
Yes,
ना?
sir.
सो
Yes.
कोई भी सिकल सेल डिजीज हो या थैलेसीमिया हो, राइट, उसमें जहां पे हाइड्रोक्सीरिया यूज होता है उसका एक ही मेन इंपॉर्टेंट अगर रीजन पूछो तो फीटल हीमोग्लोबिन इंक्रीज करना है. फीटल हीमोग्लोबिन इंक्रीज करके आप ऑक्सीजन कैरिंग कैपेसिटी, ऑक्सीजन डिलीवरिंग कैपेसिटी, एवरीथिंग गेट्स इम्प्रूव. बराबर. और जो जीन ट्रायल है, इवन इफ यू आस्क मी कि सर जीन ट्रायल में क्या करते हैं, तो जीन ट्रायल का भी अल्टीमेट गोल यही है, या जो भी न्यू ट्रायल्स आ रही है, न्यूअर ड्रग्स आ रहे हैं, बराबर, जो भी न्यूअर ड्रग्स आ रहे हैं थैलेसीमिया में, सिकल सेल एनीमिया में, उनका भी अल्टीमेट एम यही है कि फीटल हीमोग्लोबिन को कैसे भी करके इम्प्रूव करो, ताकि थैलेसीमिया में फीटल हीमोग्लोबिन इम्प्रूव करने से क्या मतलब, थैलेसीमिया में तो ज्यादा होता है, राइट. तो थैलेसीमिया में अगर आपका इंटरमीडिएट वेरिएंट है, नॉट मेजर बट इंटरमीडिएट वेरिएंट है, राइट, तो उसमें आप कैसे इम्बैलेंस कम कर सकते हो, राइट. आपका जो अल्फा चेन और बीटा चेन है उसका इम्बैलेंस आप कैसे कम कर सकते हो, राइट. सो थैलेसीमिया में भी हाइड्रोक्सीरिया इसलिए यूज होता है कि आपका अल्फा चेन और बीटा चेन का इम्बैलेंस कम करना है. जितना इम्बैलेंस कम होगा उतना उतना आपका हीमोलाइसिस कम होगा, राइट. बराबर. एंड द सेम थिंग इज फॉर, सो एंटायर genetic modification of thalassemia and sickle cell gene therapy is also based on this basic phenomenon, that if you try to increase one hemoglobin which was reduced or which was absent, right. तो हाँ, तो थैलेसीमिया में क्या होता है कि फीटल हीमोग्लोबिन आपका ज्यादा होता है, तो वहां पे आपको बाकी हीमोग्लोबिन की चेन्स इंप्रूव करके आपको इम्बैलेंस कम करना होता है. सिकल सेल डिजीज में फीटल हीमोग्लोबिन ज्यादा नहीं होता है, तो वहां पे आपको फीटल हीमोग्लोबिन इंक्रीज करा के आपको उसकी क्राइसिस को कम कराना है, ऑक्सीजन डिलीवरिंग कैपेसिटी को कम कराना है. करेक्ट.
Yes, sir.
हम्म.
Yes, sir.
या और अगर दूसरा लास्ट क्वेश्चन, कि अगर आपका सिकल सेल डिजीज का पेशेंट ऐसा बोलता है कि मेरे दूसरा बच्चा अभी पैदा होने वाला है, वो नॉर्मल बच्चा है, क्या मैं उसका कॉर्ड ब्लड प्रिजर्व करूं या ना करूं, तो आप क्या बोलोगे? कैन एनी पीडियाट्रिक डॉक्टर आल्सो आंसर दिस क्वेश्चन? कॉर्ड ब्लड प्रेशर करते हो ना आजकल?
Yes, sir. For the future stem cell transplantation.
तो हीमोग्लोबिनोपैथी इसमें कॉर्ड ब्लड प्रिजर्व करना चाहिए या नहीं करना चाहिए?
Yes, sir. It might be helpful in the future.
तो मैंने आपको सबसे पहले ट्रांसप्लांट में जब सिखाया कि ये ऑटोलोगस है या एलोजेनिक है, क्या ये ऑटोलोगस ट्रांसप्लांट होगा या एलोजेनिक होगा?
Sir, एलोजेनिक होगा, वो डोनर का.
तो खुद का खुद से तो होने नहीं वाला.
नहीं.
Allogenic will be the better.
Yes, sir.
करेक्ट. तो फिर खुद का कॉर्ड क्यों प्रिजर्व करना है, मतलब देयर इज नो पॉइंट ऑफ, राइट. और
Yes,
अगर
sir.
भाई बहन का भी अगर आप कॉर्ड प्रिजर्व करना चाहते हो,
Yes, sir.
करेक्ट,
Yes.
तो आपको पता होना चाहिए कि आपका भाई सिकल सेल डिजीज बनने वाला है कि नहीं.
Yes,
जिसके लिए
sir.
डॉक्टर गीता ने आपको इतना क्लियरली डिफरेंशिएट किया कि आप फ्यूचर प्रेगनेंसी में कैसे डिफरेंशिएट करते हो कि हमारा बच्चा सिकल सेल डिजीज होगा नहीं होगा, ऑल दोस थिंग्स, राइट. है
Yes,
ना.
sir. Yes,
एंड
sir.
द लास्ट थिंग दैट अगर आपको आपका कॉर्ड मैच है, मान लो आपके दूसरे बच्चे का बच्चा नॉर्मल पैदा हो गया और उसका जो कॉर्ड है मैच हो गया,
Yes.
बराबर, तो वो
Yes, sir.
कॉर्ड ब्लड को यूज करने की जगह आप वो बच्चे को बड़ा होने दो, 1 साल का होने दो, और उसका ब्लड सेल्स या बोन मैरो का सेल्स यूज करो, दैट इज बेटर।
Yes, sir.
करेक्ट, अगर वो 100% मैच है तो।
Yes.
बराबर, अगर वो 100% मैच नहीं है तो वैसे भी हम सिबलिंग का स्टेम सेल नहीं लेते, हम मम्मी पापा का स्टेम सेल लेते हैं,
Yes, sir.
क्योंकि सिबलिंग में से स्टेम सेल डोज अच्छा नहीं आता। सो बेसिकली द रोल ऑफ कॉर्ड ब्लड प्रिजर्वेशन इन हीमोग्लोबिनोपैथी इज नेग्लिजिबल,
Yes, sir.
क्योंकि खुद का तो खुद को काम आने वाला है ही नहीं,
Yes, sir.
बराबर, क्योंकि इसमें ऑटोलोगस ट्रांसप्लांट होता नहीं है,
Yes.
बराबर। और अगर भाई बहन का भी अगर आपने प्रिजर्व किया और अगर वो मैच कॉर्ड नहीं करा तो वो बच्चे को बड़ा होने दो ना, उसमें से प्रॉपर स्टेम सेल निकाल के उसको दो, rather than giving that immature cord cells।
Yes, sir.
और अगर वो 50% मैच नहीं करा तो वैसे भी हम वो सिबलिंग का नहीं लेने वाले हैं, हम मदर फादर का ही लेने वाले हैं।
Yes,
सो
sir.
हाँ, सो दैट इज वेरी इंपॉर्टेंट कि नो कॉर्ड प्रिजर्वेशन फॉर एनी हिमेटोलॉजिकल प्रॉब्लम्स, ओके।
Yes, sir.
बहुत इम्पोर्टेंट पॉइंट बताया सर आपने डॉक्टर चिंतन, बिकॉज यू आर ऑल्सो डॉक्टर इन योर फैमिली और इन योर रिलेटिव्स। ये क्वेश्चन आपको आएगा ही बाद में चल के कि मैडम मैं क्या करूं, करूं कि ना करूं।
Yes.
और जहाँ पे भी लोग स्टेम सेल ट्रांसप्लांट का वर्ड सुनते हैं ना, वहां पे कॉर्ड ब्लड गोज हैंड इन हैंड, मतलब 1+1 फ्री का स्कीम होता है कि भाई स्टेम सेल ट्रांसप्लांट अगर किसी ने बता दिया कि इसमें होता है तो कॉर्ड ब्लड वाले आ जाएंगे आपके पास कि सर हम इसका कॉर्ड प्रिजर्व कर लेंगे,
Yes.
बराबर।
Yes,
तो
sir.
अगर गलती से भी अगर सिकल सेल डिजीज वाले पेशेंट को पता है ना कि मेरा स्टेम सेल ट्रांसप्लांट हो सकता है,
Yes.
बराबर, तो वो कॉर्ड ब्लड के प्रति बहुत ही अट्रैक्ट हो जाएगा, क्योंकि उसको लगेगा कि नहीं ये स्टेम्स इससे भी स्टेम सेल हो जाएगा, और फिर वो लोग बोलते हैं कि हम आपको स्पॉन्सर कर देंगे जब
Yes, sir.
ट्रांसप्लांट की जरूरत पड़ेगी, तो आपका
Yes.
पैसा भी नहीं खर्च होगा। सो ऑल दीज मिस गाइडेंस हैपन,
Yes, sir.
बराबर।
Yes, sir.
नॉर्मल पीडियाट्रिक प्रैक्टिस में नहीं होता है स्टेम सेल ट्रांसप्लांट, कोई वर्ड भी नहीं सुनता है, आई थिंक तुमने भी नहीं सुना होगा इतना ज्यादा, राइट,
Sir. Yes, sir.
है ना। बट अगर
Yes.
गलती से भी अगर ये क्रॉनिक हीमोग्लोबिनोपैथी वाले पेशेंट आ गए, उनको पता है कि स्टेम सेल ट्रांसप्लांट होने वाला है, तो डेफिनेटली दे विल गेट अट्रैक्टेड टू एनी अदर ऑप्शन विच इज इजियर, सुटेबल, फ्री ऑफ कॉस्ट, ऑल दिस थिंग, है ना।
Yes,
तो
sir.
वो ट्रैप में फंस जाते हैं बेचारे।
So I think we should end this, right, Dr. Chintan?
या आई थिंक इट इज इनफ फॉर द डे।
तो बस बेसिक मैसेज इज दैट कि कोई भी केस या हिस्ट्री है ना, उसको आप केस की तरह मत देखो। आप ऐसा सोचो कि आप ट्रीटिंग फिजिशियन हो, अकेले बैठे हो, आपकी ओपीडी है, तो आप क्या करोगे।
Yes, sir.
उस हिसाब से आप सोच के करोगे तो थिंग्स विल बी इजी।
Yes.
एग्जामिनर है, वो क्या पूछेगा, मैं क्या जवाब दूंगी। उससे बेटर है कि आप सोचो कि आप फिजिशियन हो, आपको ही करना है जो करना है।
Yes, sir.
And as a case presenter, don't pretend that you know the case.
Yes.
Okay, keep your mind open to other differential diagnosis, because मैं हेमाटोलॉजिस्ट और ट्रांसप्लांटर होने के बावजूद मैं यही क्वेश्चन पूछूंगा अपने सारे पीजीज को कि what are the differential diagnosis. I am not interested in the diagnosis, I am interested in the process of diagnosis, and I am
Yes, sir.
interested in differential diagnosis.
Yes, sir.
मैं लिवर डिजीज के बारे में भी उतने ही सवाल पूछूंगा भले मैं हेमाटोलॉजिस्ट हूँ, या
Yes,
मैं
sir.
न्यूरोलॉजिकल एग्जामिनेशन के बारे में इतना ही पूछूंगा भले मैं हेमाटोलॉजिस्ट हूँ। सो
Yes,
आपके
sir.
जनरल पीडियाट्रिक्स वाले तो हमसे 10 गुना ज्यादा मतलब योर एग्जामिनर्स आर इनटू
Yes.
दिस हैबिट,
Yes, sir.
right? So they may not be asking the question which me and Dr. Geeta is asking you. They
Yes,
will
sir.
ask a question about nutrition, they'll ask a question about development, they'll ask a question about growth,
Yes, sir.
है ना। तो उस पे
Yes.
फोकस रखो ज्यादा। एंड
Yes, sir.
एनी hematology, any systemic illness, you
Yes.
have to regard all the symptoms, all the systems, not only just one।
Yes, sir.
तो ओपन
Yes.
माइंड से सोचना है एकदम।
Yes, sir.
Okay.
So thank you, Dr. Chintan and Dr. Geeta, for such an informative and interesting session. We also learn about very much important aspects of bone marrow transplant and treatment options and antenatal diagnosis.
Thank
for
you.
PG students, it is very much important to consider patient as a whole rather than just pinpointing one diagnosis. So that is very much important. Thank you.
Thank you.
Ma'am.
So I think now we can conclude this session.
Thank you. Have a nice time. Yeah.
Night. I think it's dinner time for all. Okay. Okay. Chalo.
Okay.
Bye.
Good night all.
Good night.